Ladies and gentlemen, welcome back. So it's a Symposium 1 in Woller, which is dedicated to neurology with a focus on neuromuscular crisis, stroke and brain health. It's my pleasure to invite the chairpersons onto the stage. Dr. Ajantha Keshavaraj, President, Association of Sri Lankan Neurologists. Dr. Padma S. Gunaratne.
Ladies and gentlemen, esteemed colleagues and distinguished guests, good morning and warm welcome to all Ceylon College of Physicians Neurology Symposium. It's my great pleasure to introduce our first speaker, a distinguished leader in the field of neurology, Professor Thashi Chang. Professor Thashi Chang is a consultant neurologist, professor in neurology attached to Faculty of Medicine, University of Colombo, Sri Lanka. Today, he will be sharing his insights on neuromuscular crisis for the internist, core concept and clinical actions. His expertise and dedication to advancing neurology will undoubtedly inspire all of us. Please join us to welcome Professor Thashi Chang to the stage. The floor is yours, sir.
Good morning, everybody. Thank you for that kind introduction and generous introduction at that. At the outset, let me thank the President and the Council of the CCP for the kind invitation. My talk is on the core concepts and clinical action in neuromuscular crisis. There are many neuromuscular emergencies, but the one that I'm going to focus on is the one that is potentially fatal, that is respiratory failure. My talk, this is the outline of my talk. There are 4 segments. I will take the first 2 segments together, that is evaluating neuromuscular respiratory failure and when to consider ICU care and elective ventilation. We will then discuss briefly on the different causes of neuromuscular respiratory failure, and in the final segment, I will discuss on 2 conditions, neurological conditions, which are the most common in causing respiratory failure. Here we go. Let's start with a real-life clinical scenario. A previously well 22-year-old woman presented with ascending limb weakness over 2 days. Her muscle power was 4-5 in all 4 limbs, and she needed support to ambulate. All tendon reflexes were diminished, and plantar responses were flexor. She was noted to have mild bilateral facial weakness. She had a weak cough effort, and a forced vital capacity was only 15 milliliters per kilogram. So you need to answer 3 questions. First, would you admit her to the intensive care unit? Second, would you electively ventilate her? And third, what specific therapy would you initiate? Now let us get on with the lecture. Remember the case because I will put it up a bit later, and then you need to answer the 3 questions. So remember the questions as well. When evaluating neuromuscular respiratory failure, there are some key physiologic concepts. The diaphragm is the main inspiratory muscle. It accounts for 2/3 of the ventilatory effort. We all have a substantial respiratory reserve, but ventilator failure occurs when diaphragmatic function falls below about 1/3 of its normal baseline function. However, if patients have lung parenchymal disease, airway disease, or they have conditions such as bulbar palsy, which would collapse the upper airway, then respiratory failure would occur earlier before the diaphragmatic function falls significantly below its normal function. Now let us look at how patients present in impending respiratory failure. So patients will have shallow rapid breaths, tachycardia, diaphoresis, and their sentences would be interspersed with breaths that they have to make. So it sounds a staccato sort of speech. And a useful sign would be the paradoxical breathing pattern. In a normal patient, when the person inspires, the thoracic cavity would expand and the chest wall would move anteriorly outwards. And because the diaphragm moves downwards, then the anterior abdominal wall also will move outwards. However, if there's diaphragmatic paralysis in inspiration, the chest would move outwards, but because the diaphragm is pushed upwards now, the abdomen will move inwards. So that is the paradoxical breathing pattern that is useful in identifying impending respiratory failure. Now let us look at the simple tests that we can do in identifying early acute respiratory or impending respiratory failure. The single breath count is a very simple test because you don't need an instrument. All you need is to ask the patient to take a deep breath and count maximum on a single expiratory breath. So you tell the patient 1, 2, 3, 4, 5, 6, 7, 8, and usually normal people are able to do more than 25 in a single breath. However, if you have instruments like a respirometer, then you can measure the forced vital capacity, the maximal inspiratory pressure and the maximal expiratory pressure. And two other investigations that are useful is the chest radiograph. As I alluded to earlier, the presence of parenchymal lung disease or airway disease would tell you that this patient is going to have trouble earlier. And the arterial blood gas. In ventilated failure, type 2 respiratory failure, you expect a hypercapnia. But the caveat is, in a patient who is tachypnic, if the patient has normocapnia, that too implies impending respiratory failure because that means there is ineffective breathing, that is just dead space ventilation. Now let us look at the criteria in which we would admit a patient to the intensive care unit and electively ventilate. So that brings us to the 20, 30, 40 rule. 20 is a single breath count less than 20, forced vital capacity less than 20 ml per kg, so that is in a 50 kilogram person less than 1 liter, or if there's a more than 20% drop from upright to supine position in the forced vital capacity, or if the MIP is less than 30 or MEP less than 40. Now these are just arbitrary values, but if there's a progressive drop in your serial measurements, then you don't wait till the patient reaches these values. You get the patient into the ICU and you electively ventilate. So that is very important to appreciate. For example, a forced vital capacity in a 50 kilogram person would be about 3.5 liters. When the patient admits, if the first measurement is 3 liters and 2 hours later it is 2.5 liters, you're not waiting till the patient reaches 1 liter to get the patient into the ICU. A very simple rule of thumb would be the forceful cough effort. You ask the patient to give a good cough. So if the patient can give a good cough, that means more than 1000 ml. But if you ask the patient to give a cough and the patient goes, then you know you're in trouble because you need to get the patient quickly into the ICU. That means it's less than 1 liter. Right, so that's the first segment. We have now learned about how do we evaluate neuromuscular respiratory failure, and we learned about the 20, 30, 40 rule, the criteria by which we would admit the patient into ICU and electively ventilate. Now let us briefly look at the causes of neuromuscular respiratory failure. This is a cartoon of the lower motor neuron, so you can see the anterior horn cell there. Nerves emerging, the nerve root, the peripheral nerve, neuromuscular junction, and the muscle. And conditions, neurological conditions that can affect any one of these levels and cause acute neuromuscular respiratory failure. At the anterior horn cell level, you have motor neuron disease and West Nile virus infection. At the nerve root and the peripheral nerve, you have Guillain-Barré syndrome, critical illness neuropathy, vasculitis, and porphyria. At the neuromuscular junction, you have myasthenia gravis, organophosphate poisoning, snake envenoming, botulism. Snake envenoming is quite common this part of the world, so for our foreign delegates, we do see quite a number of snake envenoming. And at the muscle level, we have critical illness myopathy, inflammatory myositis, metabolic myopathies, and toxins. Right. Now let's get on to the final segment of my talk, which is to discuss on the 2 most common neurological conditions that result in neuromuscular acute respiratory failure. Let's start with Guillain-Barré syndrome. From the cartoon, you now know the site of lesion. Guillain-Barré would affect the nerve roots and the peripheral nerves. It's most commonly a post-infection disorder occurring after gastroenteritis or a lower respiratory tract infection. Campylobacter jejuni has been implicated as the most common infection. However, there are other infections like cytomegalovirus, Epstein-Barr virus, HIV, mycoplasma, Haemophilus, Zika, and COVID that can trigger Guillain-Barré syndrome. It is believed that Guillain-Barré syndrome occurs due to an immune attack, a molecular mimicry where antibodies are produced against the infectious agent which cross-react with the patient myelin ganglioside. Now, it is important to remember that pathogenesis because the treatment is based on the knowledge that it is an immune attack and that there are antibodies that are directed against myelin gangliosides. Now, this is a little animation on the pathogenesis. As you can see, you can see nerve impulses passing through the nerve terminal, a myelinated nerve terminal, quite very rapidly. Now, if you watch again, it goes very rapidly to the nerve terminal, nerve axons. And then when it's demyelinated, you can see the impulse slowing down quite significantly. And then the nerve remyelinates over weeks, and it reestablishes its nerve conduction. Again, an important point to remember, because Guillain-Barré syndrome is reversible, and it just takes the time to remyelinate. Once it remyelinates, the patient makes an almost complete recovery. What are the clinical features? It has a very typical presentation. The patient presents with an acute ascending paralysis, where the patient will develop weakness of the lower limbs, followed by weakness of the upper limbs, and then it will affect the cranial nerves, most commonly the facial nerves and the bulbar muscles. In fact, any patient who has bilateral low motor neuron facial palsy, it is Guillain-Barré syndrome until proven otherwise. You may see the patient early in the disease where the patient may have just lower limb weakness. But when you test the tendon reflexes, even the upper limb tendon reflexes would be absent at that point even when there's no weakness in the upper limbs. And that is what is known as global areflexia, which is a typical feature of Guillain-Barré syndrome. Many patients may have sensory symptoms, but usually they don't have sensory signs. If you look at the progression of Guillain-Barré syndrome, by definition, it does not progress beyond 4 weeks because it's an AIDP, acute inflammatory demyelinating polyradicular neuropathy. The term is descriptive. Acute means over hours to weeks. Inflammatory demyelination tells you the pathology. And the site of lesion is the nerve root and peripheral nerve. Radicular means nerve root, radicular neuropathy. As opposed to CIDP, which will continue to progress beyond 4 weeks. So this is, by definition, less than 4 weeks. However, patients reach their maximum weakness within the first 2 weeks. And that is the crucial period because about 25% will develop respiratory paralysis in the first 2 weeks. And about a third will develop autonomic dysfunction. And these are the two potentially fatal complications of Guillain-Barré syndrome. Therefore, if we manage patients, if we save the patient within the first 2 weeks, they make a good recovery. So our period of time is the first 2 weeks in looking after these patients. How do we diagnose patients? Primarily clinical, and that is why I emphasized on the clinical presentation because we make the diagnosis clinically. Of course, there are investigations where CSF will show the typical albuminocytological dissociation where there is a high protein and a low no cells. And on the nerve conduction study, because the majority of patients will have demyelination, you will find features of demyelination. The caveat is that these changes occur 10 to 14 days after the onset. So practically they are useless. So you need to make the diagnosis clinically. Personally, I do not do lumbar puncture in patients with Guillain-Barré syndrome unless they have atypical presentations. Now let us look at the treatment. Fortunately, there's disease-modifying treatment. I told you this is immune-mediated attack on the peripheral nerves. So either IVIG or plasma exchange have been found to be effective in reducing the time to recovery, the need for ventilation, and residual disability. Most beneficial if it's treated in the first 2 weeks. So if the patient comes later, they are not going to get that much benefit from this immunotherapy. The efficacy, IVIG and plasma exchange are almost equal in efficacy. Of course, patients who have autonomic dysfunction will not tolerate plasma exchange. So in which case, IVIG will take preference. There are two therapeutic dilemmas that come on with these treatments. If IVIG and plasma exchange are both effective, why not combine it? And fortunately, fortunately, there's RCT evidence showing that combination of IVIG and plasma exchange is no different to either agent alone. Then the next therapeutic dilemma is, what about a higher dose or repeated dose of IVIG in patients with Guillain-Barré syndrome? Again, there's RCT evidence from 2021 which shows that there is no benefit in a second dose or repeated doses of immunotherapy. So it's a single IVIG dose or plasma exchange in Guillain-Barré syndrome. What do we do when patients develop respiratory compromise? We identify the impending respiratory failure using our 20, 30, 40 rule. So if a patient has a single breath count less than 20 or forced vital capacity less than 20 ml per kg, we get the patient into ICU and we electively ventilate. Non-invasive ventilation is not recommended because by the time Guillain-Barré presents, the diaphragm is already paralyzed. And as we saw in the pathogenesis, it takes several weeks for remyelination. So it takes several weeks for the patient to recover, and you can't keep patients on NIV for several weeks. So you need to go for invasive mechanical ventilation. So let us come back to our case, which we just discussed, and you need to answer the 3 questions. So here is a young woman who presented with ascending paralysis. Over 2 days, her muscle weakness was 4- in all limbs. Tendon reflexes were diminished. She was noted to have mild bilateral facial weakness. Cough reflex was weak. And the forced vital capacity was 15 ml per kg. Would you admit her to the ICU? Can I see a show of hands? Yes? No? 1, no? Right? Would you electively ventilate her? Yes? No? Right, there are a few no, okay? What specific therapy would you initiate? So it is either IVIG or plasma exchange. Right, so we come to the last disease that I want to discuss with you is myasthenia gravis. Again, from the cartoon, you know that myasthenia gravis is a disease of the neuromuscular junction. And there is my little cartoon of the neuromuscular junction. The green terminal is the green is the nerve terminal, and in brown you have the muscle, and in between you have the sinus, which is in here is the neuromuscular junction. There are some important proteins I want to introduce you to on the postsynaptic membrane. That is the MuSK, or muscle-specific tyrosine kinase, and RP4, which is the lipoprotein-related, receptor-related protein. And then you have the AChR receptors on the postsynaptic membrane. Now follow the animation. When a nerve impulse comes down the nerve terminal, you will have agrin, a protein being released which will bind to MuSK. And MuSK will then, that complex will release a protein called rhabsin, which causes clustering of the acetylcholine receptor. And it is the clustered acetylcholine receptor that gives the most efficient neuromuscular transmission, right? So what happens in myasthenia gravis is that there are antibodies that are pathogenic. So myasthenia gravis was the first prototype autoimmune disease that was shown where antibodies are pathogenic. And these antibodies are directed against the acetylcholine receptors. These antibodies are IgG1, which means they activate complement. And that complement activation causes destruction of the acetylcholine receptors. Now, if you look at the animation, you can see there's a reduction of the number of acetylcholine receptors on the postsynaptic membrane. So remember that again, because the treatment is based on the knowledge that this is an antibody-mediated disease. Right, so in about 85% of patients using radioimmuno precipitation assay and perhaps higher in cell-based assays, we detect 8 acetylcholine receptor antibodies. They are almost 100% specific. No other disease has acetylcholine receptor antibodies. The question is, what happens with 15%? What causes disease in 15% of patients if we can't detect acetylcholine receptor antibodies? Well, about quarter century ago in Oxford, they discovered antibodies against MuSK. So when you have antibodies, watch the animation, you can remember the cartoon where there's agrin, MuSK, LRP4 complex will release rhabsin, and rhabsin will cause clustering of the AChR receptor. The clustered receptors are the most efficient. So what happens here is that when there's antibodies against MuSK, the rhabsin disappears and the receptors are declustered. So there's inefficient neuromuscular transmission. And here in Sri Lanka, we found that about 20% of our patients will have MuSK antibodies who are negative for AChR antibodies. Clinical presentation of myasthenia gravis, there are two main subtypes, the ocular myasthenia gravis and the generalized myasthenia gravis. Even if patients have generalized myasthenia gravis, the first presentation, the commonest presentation are ocular symptoms. However, the majority of patients will progress to develop generalized myasthenia gravis within 2 years. Therefore, ocular myasthenia gravis is a retrospective diagnosis, meaning we have to wait 2 years to say that it is confined to the ocular muscles, because it can progress to generalized within 2 years. The hallmark clinical sign in myasthenia gravis is fatigability. So if you look at that video, and that's a beautiful demonstration of eyelid fatigability in a patient who presented with asymmetrical ptosis. Of course, in the audience, both eyes might ptose and fatigue, but if it's asymmetrical ptosis, it is myasthenia until proven otherwise. And also the take-home message is, if you have a patient with tossed eyelids, make sure that you test for fatigability, otherwise you can miss the diagnosis. How do we diagnose myasthenia gravis? Mostly clinically. In this part of the world, we diagnose myasthenia gravis clinically, but of course there are clinical tests, there are neurophysiological tests and antibody tests. Clinical tests, IGAP test, which I will show you in a moment, or we can give the patient pyridostigmine, which will increase the acetylcholine concentration in the neuromuscular junction. Neurophysiological tests include repetitive nerve stimulation and single fiber EMG. Single fiber EMG is more sensitive than repetitive nerve stimulation, but both of them may be negative in patients. Antibody tests we have already talked about. Now here is a patient, young patient with a left-sided ptosis. We apply ice, just cold ice, for 1 to 2 minutes, and then the eyelid opens. So that is the IGAP test, highly sensitive, highly specific for myasthenia, but it can be applied only in patients who present with ptosis. How do we treat myasthenia? We go back to our pathogenesis. We know that it is antibody mediated. So there are 4 modalities. One is symptomatic, immunotherapy, transient immunomodulation, and surgery. Symptomatic, we saw from the cartoons that because there is interruption or there is reduction in efficiency of acetylcholine neuromuscular transmission, we can increase the acetylcholine at the neuromuscular junction by using anticholinesterase like pyridostigmine and neostigmine. However, the pathogenesis is mediated by antibodies. So the disease-modifying treatment would be immunotherapy. The traditional immunotherapy has been broad spectrum, like corticosteroids, azathioprine, mycophenolate, and so on. So broad spectrum means more adverse effects. But now there's precision immunotherapy, and the medication that we commonly use would be rituximab, which is anti-CD20. We know it is antibody mediated. CD20 is found on B cells. So if we knock off the B cell population, then we reduce the amount of pathogenic antibodies. And that is one mainstay of treatment. And then there's eculizumab and ravulizumab. I told you that the antibodies mediate complement-mediated destruction of the receptors. So what these agents do is they're anti-membrane attack complex medication that interferes with the membrane attack complex formation in the complement system. So it's more downstream, more precise, less adverse effects, much more effective. And these drugs have been proven to be effective. And the new kids on the block are the efgartigimod, rozanolizumab. These monoclonal antibodies are against the Fc portion of immunoglobulins, reducing the number of immunoglobulins in circulation. And then we have transient immunomodulation with IVIG and plasma exchange. So they act fast, but the effect doesn't last because they will transiently reduce the amount of antibody attack. Surgery. About 70% of seropositive, meaning AChR antibody positive myasthenia gravis will have thymic hyperplasia. Now the thymus is the factory that is producing the antibodies. So in patients with thymic hyperplasia, if you do thymectomy, they have a fantastic clinical improvement. There is RCT evidence for that. But it is most beneficial in patients who have the onset of disease early, before the age of 50. When you do it early in the disease, before, where lymphocytes will go to other sites, when it is still in the thymus, that is less than 5 years after the onset, and in patients who are seropositive. Also, about 10% of patients with myasthenia gravis will have a thymoma. Thymoma is a locally invasive tumor. It does not produce antibodies, but because it's a locally invasive tumor, we need to remove the thymoma. So in all patients with myasthenia, we screen for any thymic pathology. Right, now let's look at the myasthenic crisis. The common triggers we must identify, because myasthenic crisis occur in patients who get infection, patients who default their treatment, or patients who are given inadvertently antibiotics by their GP, perhaps ofloxacin, levofloxacin, which will interfere with neuromuscular transmission. They have worsening weakness that goes over days, and as a result, they're taking more and more pyridostigmine. So what happens is, superimposed on the myasthenic crisis, they also have a cholinergic crisis. Cholinergic crisis in isolation is excessively rare, so you don't have to worry too much about that. In myasthenic crisis, unlike in Guillain-Barré, there is a window of opportunity. If you institute NIV, non-invasive ventilation, treat the patient with the rapidly occurring immunotherapy like IVIG and plasma exchange, we might get away without mechanical ventilation. However, BiPAP needs to be instituted early, because by the time the patient develops hypercapnia, it's too late. All patients in crisis should receive corticosteroids, and there's no evidence again of combining IVIG and plasma exchange. It is either this or that, but plasma exchange works faster than IVIG in myasthenia gravis. And sometimes we are stuck with this problem where patients, we cannot wean them off the ventilator. And that is when the rituximab comes into play. It's a fantastic medication. It is now, it doesn't have a patent, it is cheap, you can institute it, it's a fantastic medication, it works like a prayer. Use it in myasthenia gravis, both in MuSK and ACHR. It is more effective with MuSK than ACHR. So in summary, ladies and gentlemen, that's the end of my lecture. But I had an ulterior motive here in my lecture. The ulterior motive is to protect the brain. And that is why we want you to do the ventilation before the patient arrests. We want you to ventilate the patient before arrest, because in arrest, you know, there is a delay. We don't want even 10 seconds of hypoxia to the brain. We need to protect that brain. So the ulterior motive is to protect the brain, institute the ventilation early, the ventilation, because that will protect the brain. And that is why the 20-30-40 rule might be useful to remember, because that is when you will get the patient into the ICU and electively ventilate before the patient has arrest in a busy ward. Sri Lankan wards are like, you know, battlefields, so it is very difficult to get something done early, so better to get patients into the ICU. Rapid initiation of targeted immunotherapy improves outcome in both Guillain-Barré and myasthenia, as I gave you the evidence. Thank you very much.
Thank you very much, Professor Thashi. May I invite Professor Thashi to come and sit with us here? Let me introduce our next speaker. He's our foreign speaker, Professor John Woller. Professor John Woller is a general internist practicing in the Johns Hopkins in Baltimore, Maryland, USA. He completed medical school at Emory School of Medicine in Atlanta, Georgia, and internal medicine residency in the Oslo program of Johns Hopkins. He's now the Associate Program Director for Bedside Medicine for the Oslo Medical Residency Program. So he would be talking to us on acute stroke, the role of the internist. So, Professor John Woller.
All right, good morning, everyone. Thank you so much for the opportunity to speak today. You may notice that I am not a neurologist, so I hope I don't embarrass myself too much in front of our other speakers. But I'm going to be talking about the role of the internist in acute stroke, and I do think we have several important roles to play. So our learning objectives, we're going to be talking about the role of the internist in the primary prevention of stroke, the recognition of acute stroke, in the management of the stroke itself and of comorbidities, of the diagnostic evaluation of the cause, and of secondary prevention. So really the most important thing that we can do is to prevent them in the first place. I do believe this is true, an ounce of prevention is worth a pound of cure. So which of these factors, if we adjust them, these are modifiable risk factors for stroke, has the biggest impact. And so let's take a brief look at that. This is a really interesting, extremely large pooled cohort study including 34 countries, and looking at the risk attributable proportion of strokes with 5 modifiable risk factors: BMI, smoking, diabetes, cholesterol, and blood pressure. And overall, over half of major adverse cardiovascular effects worldwide, events, not effects, are probably attributable to these 5 modifiable risk factors, and to probably 20% of all deaths. And these are just some interesting graphics showing the probable effect of each individual factor. And you can see they're striated by men and women here, but the effect of each individual factor is significant. But just because these are causative, at least as far as we can tell, doesn't mean that modifying them actually will prevent strokes. So we do have many studies, which will be referenced at the end, showing that if we can get patients on proper blood pressure medications, and this mainly will mean calcium channel blockers, diuretics, and ACE and ARB inhibitors, that will reduce the risk of stroke by at least 28%, possibly more. Smoking cessation has a tremendous effect, and so getting patients medication-assisted or non-medication-assisted smoking cessation is tremendous. And then getting patients on statins, ezetimibe, and PCSK9s, if available, to reduce their cholesterol, even before they've had their first event, will reduce their stroke risks significantly. There's no randomized evidence that weight loss itself will help. Logically, it should. And then diabetes management, lowering the A1C per se does not necessarily reduce the risk of stroke, but certain medication classes, including the GLP-1s, if you can get them, metformin and thiazolidine diones, do reduce risk of stroke as well. So, unfortunately, some of our patients do go on to have acute strokes despite the work we do in the primary care clinic. And so there's many, many presentations of acute stroke, but I would argue it should always be on our mind, especially in patients with risk factors, and for any acute neurological change. And so we want to be highly attuned to the possibility of stroke when we have anything that could localize to the brain. There are 3 findings in particular that have the highest likelihood ratio for an acute stroke if we see them. And those are facial paralysis, arm weakness or drift, and abnormal speech, which could represent either dysarthria or aphasia. And this has been turned into a mnemonic, the ACT FAST, for face drooping, arm weakness, speech difficulty, and then the T is time. This is not just for physicians, this is for people out in the community, for family members. This is from the American Stroke Association. So this is something that we want to not only recognize ourselves, but also transmit to our patients and their families. And seeking emergent attention is what we want to convey to our patients as what they should do in these situations. However, the challenge is that many other things than stroke cause acute neurologic change, even focal deficits. And the list is honestly tremendous, but seizure, hypoglycemia, migraine, complex migraine, intracranial hemorrhage, traumas, toxidromes. We see, unfortunately, quite a few toxidromes where I practice, and many other things. Recrudescence is a very common presentation where we see a patient who had a previous stroke, has a systemic illness, and then their prior deficits reappear. So this is tough, right? There's a lot of things that can look like a stroke, and there's a lot of things a stroke can do. But because of the potential consequences, we should take this very seriously. So what do we do if someone presents with an acute neurological deficit that may be due to a stroke? Well, first, as always, is ABCs. We manage the airway, we make sure the patient is breathing, and we attend to their circulation. In other words, check a pulse and manage their blood pressure, right? Sometimes we teach these in a different order, CABs. For adults, either way you do it is fine. Airway can be compromised in bulbar dysfunction if the patient is in a coma, if they have vomiting associated with their stroke. Breathing can be impaired either by impaired respiratory drive if there's brainstem involvement, or if there's bulbar issues as well. We don't want to over-oxygenate patients. Actually, that does cause harm, worsening outcomes and increased risk of mortality. But we want to get them above about 94% oxygen saturation. And then, of course, circulation. If a patient presents hypotensive and they're having a stroke, that's not very common. Most patients will be hypertensive. And so you should really think about an underlying cause of sepsis, aortic dissection, severe heart failure, some other systemic problem that's leading to the stroke that you're seeing. We'll talk more about hypertension later. And then once we have a patient stabilized well enough that we can get additional testing, there's 3 things that we should do without delay. And nothing should delay these tests other than the management of the ABCs. And I would propose in this order that they should be oxygen saturation. As before, we want to ensure that we're oxygenating our patients properly. Fingerstick glucose, or the most rapid glucose test you can get. Stroke is not a stroke until you've given somebody glucose for hypoglycemia, because in addition to global encephalopathy, hypoglycemia can cause focal deficits as well. And then a non-contrast head CT. And this should happen as soon as possible, and I recognize in some places it may not be possible to get a head CT as timely as we would like, but if at all possible, we want to exclude a hemorrhagic stroke in order to properly proceed with treatment of the patient. And as before, nothing should delay these in a suspected stroke other than management of ABCs. So the next thing we want to do is we want to establish the syndrome. A very focused history is going to be very important here, especially focused on acute symptoms. Many of our patients will have had strokes before and have baseline neurologic deficits. We want to identify when did the acute symptoms start and exactly what are they. Use collateral from family or bystanders if at all possible. Recognizing aphasia, dysarthria, or coma, which are relatively common complications of stroke, may prohibit the taking of a history as we would like to. This is in the first really minutes of meeting the patient. We're trying to understand what's the syndrome, where does this potentially localize, right? And in particular, we want to know the time of onset. And this can be one of the most challenging things, especially to get from a patient who is altered or confused. The last known normal is an extremely important concept in the management of acute stroke because it's going to determine the patient's candidacy for thrombolytics or for catheter-directed thrombectomy if available. And so we really want to go out of our way to make sure we fully understand the patient's last known normal before their acute symptoms developed. Patients who wake up with deficits are very challenging. We call these wake-up strokes. Recently, there is some data that MRI showing flare and DWI mismatch will make some patients candidates for therapy who previously were not. Again, depends on the availability of very rapid MRI in your center, which may or may not be the case. There are newer studies that are exploring whether we can extend these windows, but our typical window that we consider to be the maximum in the absence of additional data would be 4.5 hours from stroke onset to the revision of thrombolysis. And then catheter-directed catheter-directed thrombectomy, where available, maybe up to 24 hours. The nuances of this are probably outside of the scope of this talk, and our neurologists could probably speak more to those than I can. But these are the numbers I think we should all be aware of, regardless of our setting of practice. Next thing we want to do, after we've identified a stroke and determined the patient's candidacy for therapy, is to grade the severity of it. The NIH stroke scale, or NIHSS, is probably the most widely recognized and used globally. It's a scale from a 0 to 42. And it's important to recognize this is not a diagnostic tool. Many other things than a stroke can cause a very high NIHSS. A patient who's comatose from any reason would have a high score. But it is important to grade the severity. And rather than memorizing it, which I don't know there's a good use of your time, if you have a smartphone, you can just put it into Google. And there's many tools you can use that will not only tell you, but also will add the score up as you go, right? So if you just go to MD-Calc, for example, which I have no relation with, I just like their tool, then it'll pop up and it'll put them in order, and as you sort of click the buttons as you're assessing the patient, it will add it up as you go. So you can focus on assessing the patient, not worrying about remembering the steps or doing the math, right? So although it does put a phone in your hand, I think it actually allows you to pay more attention to your patient. These are the components, not going to go through them in detail, but just to note they should be done in this order. There are some specific instructions as well, so if you've never done it before, a patient who's having a stroke is probably not the first time to read the instructions, so do take the time to familiarize yourself with this. But just know that it is available as well at your fingertips if you need it. All right, so as we're making the decision what therapy is this patient a candidate for, we want to also attend to additional history and physical. This is our superpower as internists, right, is to take a history and physical. And so we want to be noting the patient's past medical history. especially prior stroke, history of intracranial hemorrhage, crucial in the decision for TPA, other vascular risk factors, any other neurologic conditions that could mimic stroke. Medications are important, especially blood thinners. If the patient's taking a blood thinner, when did they take their last one? This is a pick up the phone and call their family if they don't know. You really have to know this. Or if they're immune compromised, that can change your differential as well. You want to briefly attend to their family history and other risk factors, and then think about substance use, alcohol, other non-prescribed substances, and then risk factors for other infections such as syphilis, HIV, varicella zoster, HSV, which can also, through the mechanism of vasculitis, also cause acute stroke. When we examine patients, really we should be doing our same history and physical that we would do upon meeting a patient with a vascular disease, but there's some particular things we want to pay special attention to. So signs of sepsis, signs of shock from any cause, general frailty. We're going to be doing a very thorough vascular examination, looking head to toe at the carotids, femorals, brachials, signs of dissection, signs of other arterial embolus that we may find. And then tongue laceration may point us actually toward a seizure instead of a stroke as the cause of the deficits. We want to be very attentive to signs of congestive heart failure, AFib, and other arrhythmias that could be the cause of the stroke. Pulmonary system can be affected by aspiration. There could be stridor from bulbar dysfunction. There could be bronchospasm or pulmonary edema as well, depending on the comorbidities. And then especially, we want to be very attentive to signs of endocarditis. Where I practice, we see quite a few strokes from infective endocarditis, unfortunately related to injection drug use, which would be a firm contraindication to giving thrombolysis. So this is something we want to be very attentive to. And then something like cholesterol emboli, signs of recent surgery, ecchymosis, or hematomas that can indicate a bleeding disorder. So essentially, all patients should have a certain set of studies. I'm not going to read them to you, but these are things that we're probably, if we're the primary bedside provider or if we're the one meeting the patient, ordering these things. And they're pretty intuitive. Some patients need additional investigations, studies to look at the potency of effect of blood thinners, to look for signs of liver disease, pregnancy tests if the patient's childbearing potential, studies to look for toxidromes, a blood gas if we're concerned about their ventilation or oxygenation, and investigation for signs of sepsis, lumbar puncture if we're concerned about either an infectious syndrome or SAH, and then EEG if a seizure is suspected either before or as a consequence of their stroke. So the decision to administer thrombolytics is, in some settings, a decision that may be made by an internist. In my hospital, it's generally not, but I think it's still very important to know these criteria. So as before, onset within 4.5 hours, or if there is CT imaging of salvageable brain tissue, CT or MRI evidence of salvageable brain tissue in the first 24 hours. And then if they don't have exclusion criteria. And the exclusion criteria also pretty extensive here. I think it is probably not a good idea to attempt to memorize these. This is something where you should really be checklist oriented, and you can pull these up again on Google at any times. So we'll move on from that. And then there are warnings or relative contraindications. This is where I think things become very challenging because this is a risk-benefit decision, and there's no sort of textbook that's going to tell you, is one of these relative contraindications going to be something that should exclude your patient from getting a potentially life-saving therapy, and so things to be aware of. Once we have made the decision to give TPA or not, then our blood pressure goal is going to change, right? If a patient is a candidate for thrombolytic therapy or if they have received thrombolysis, we want to have a stricter blood pressure goal to reduce the risk of intracranial hemorrhage. Whereas if they are not getting TPA, we want to allow for permissive hypertension, which is the brain's own response to try to protect itself and perfuse the ischemic area. So for patients who will get or have gotten TPA, we want to try to keep the blood pressure below 180/110, and in patients who are not candidates for TPA, actually 220/120 as our upper limit, which feels very high to some of us, but in that acute first 24 hours, we want to allow the brain to perfuse itself. We should be having patients in the ICU, we should be using IV titratable antihypertensives. Nicardipine, labetalol, others are perfectly fine. If the patient also has heart failure, nitroprusside is very quickly titratable and may be beneficial for management of their heart failure as well. You want an arterial line in most of these situations. So we want to be careful about not lowering the blood pressure too soon, regardless of the situation. The cerebral autoregulation is impaired in patients with chronic hypertension. If we lower the blood pressure too fast, even to a normal range in a patient who's been living with a systolic blood pressure of 190 for years, we may actually cause watershed infarcts and worsen their disease, even apart from the acute stroke. Just a concept to be very familiar with. So even after that first 24 hours, once we're through the permissive hypertension window, we don't want to be lowering our patient's blood pressure by 50 points over the course of a few days. We want to do this gradually over days to weeks. And so if we have a hemorrhagic stroke, just to briefly mention, there's no data to guide the management of blood pressure here. Expert recommendations are generally to more rapidly lower the blood pressure, but there is a balance between stopping the bleeding or slowing the bleeding and preserving that threatened brain tissue. So just a quick note that this is very different in ischemic rather than hemorrhagic stroke. Now let's move on to the complications and comorbidities. This is another area where I think as internists we can potentially be very helpful in management of patients with stroke. Hypovolemia is quite common in patients presenting with stroke, not uniform. Again, many patients may have heart failure, but generally patients will tend to present volume down. We should maintain electrolytes as we normally would, being cautious of SIADH as a potential complication. The fever that can present with stroke most often is due to an underlying systemic cause, an aspiration pneumonia, a UTI, or perhaps sepsis, endocarditis, so that should be investigated. Some patients can present with a fever from the stroke itself, a central fever, as we say, which is a very bad prognostic sign. There are some expert recommendations to try to aggressively manage temperature during the first couple of days of stroke. When this has been studied, it's not come out to be that beneficial, but we should at least be mindful of not letting patients have too high a fever to decrease the metabolic demand of that threatened brain tissue. Glucose management, also very important here. We want to keep the glucose in reasonable control, but there's no benefit to very tight control in the context of acute stroke. And hypoglycemia, on the other hand, we should be very aggressive about correcting that, both because it can mimic stroke and cause a false positive diagnosis, but also hypoglycemia is going to worsen that neuronal injury. The brain is very dependent on glucose for its food supply, as it were. And then prevention of complications, just as our first slide, prevention is worth much more than cure, right? Patients are very prone to develop pneumonia after stroke. We should do a formal swallow study after an acute stroke before we allow our patients to take PO. A bedside water swallow test is simple, safe, and quite sensitive for bulbar dysfunction. We just give the patient a cup of 90 cc's of water and ask them to drink it at bedside, and if they can do that, then that's fine. If they have any trouble, if they have coughing, or if it takes them more than about a minute, then we should have a formal swallow evaluation before we allow them to take by mouth. DVT prophylaxis, also important, and then we want to mobilize and have PT involved, ideally on day 2, but noting 25% of patients will have falls. And there's many other complications that are very common after acute stroke. Many of the things our patients get in the hospital anyway, infections, pressure ulcers, and then many patients will also have underlying comorbidities that will emerge. Now, in terms of the evaluation of the etiology of the stroke, in terms of what caused it, I think this is pretty interesting. If you look at the cause of strokes, you see there's a pretty even split here between lacunar strokes, which are deep, small vessel atherosclerotic disease, cardioembolic from a number of causes, large artery atherosclerosis such as carotid disease, embolic stroke of unknown origin, and non-embolic stroke of unknown origin. Those are fairly evenly split. There's a small category here of other, and the 2% that are seen here are the subarachnoid hemorrhage and intracerebral hemorrhage. Overall, about 15% of strokes are hemorrhagic worldwide, so I believe that 10% on here is mostly other hemorrhagic strokes. But so it's not as if there's a single hugely dominant cause. So when we think about it, again, our history and physical is our guide here. Do they have signs of an infection? Do they have signs of meningitis? Do they have congestive heart failure? Do they have signs of infective endocarditis? We want to be very careful in scrutinizing their EKG, and they should be on telemetry cardiac monitoring for at least 24 hours. And if they have a cryptogenic stroke or an embolic stroke of unknown origin, should be longer. Echocardiography is indicated for most patients who have stroke. Transthoracic is generally appropriate as a first step, but if you have access to transesophageal echo, it is quite a bit more sensitive for many of the things that cause stroke, including left atrial thrombus, LV thrombus, patent foramen ovale, LV non-compaction, and other genetic cardiomyopathies, intracardiac tumors, and then signs of endocarditis, as well as proximal aortic pathology, which can also embolize to the brain. So we should have a low threshold to engage our cardiologist for TEE if we're not confident of the cause of the stroke. And then we should think about a hypercoagulable workup as well. The extended cardiac monitoring should be for patients who have a higher risk of AFib if we don't catch it in that first few days of monitoring. So if they're older, if they have abnormal P waves, if they're frequent ectopy, if they have signs of heart failure, or even if they just have a family history. So if you have access to a home monitor, an extended monitor that the patient can wear at home for a couple of weeks, many times of cryptogenic stroke will actually catch AFib after the fact and then start anticoagulation. All right, in terms of secondary prevention, there's some things that we should start off the bat. Almost all patients should get a statin early. Even if we don't think this is an atherosclerotic stroke, if we're not sure, just give the statin. Because even in that first couple of days, the stabilization of atherosclerotic plaque effect from a statin can have some early beneficial effect. And most patients will also end up getting aspirin as well. Unless they're getting TPA or unless they have an indication for full dose anticoagulation, we should start aspirin generally within 24 hours. 325 or equivalent to start with, and then 81 milligrams or equivalent after that daily, 50 to 100 milligrams. And there's no need to wait for the completion of stroke workup to start aspirin here. There are some early beneficial effects as well. Certain patients need dual antiplatelet therapy, clopidogrel plus a statin. These would be folks with a non-severe stroke in order to prevent that bigger second one, or patients who have a large intracranial stenosis, 79 to 99%, different durations of the DAPT there that you can see. And then some patients will need full dose anticoagulation if they have essentially a cardioembolic source, AFib, LV thrombus, et cetera. Don't start that right away. The risk of hemorrhagic transformation is significant in the first few days of stroke if you immediately start someone on heparin or apixaban, for example. But generally that 7 to 14 day window is appropriate. Some very large territory strokes are going to have a higher risk of hemorrhagic conversion, and so if you can, consult with a neurologist about those cases before you start them on full dose anticoagulation. And then returning to where we started, prevention is worth a lot more than cure, right? So our patients who have had strokes are obviously those at higher risk for having another. So we want to keep their blood pressure less than 130/80 if they can tolerate it. It's a little bit tighter control than we would seek for most of our patients who have not had an adverse cardiovascular event. Again, using those agents that we really prefer, ACE, ARB, diuretic, and calcium channel blockers. Beta blockers generally do not have as much effect in preventing stroke as the other agents. We really want to work on smoking cessation, which can decrease the risk of future events by half, keep that cholesterol under 70 or under 55, depending on which guideline you look at. And then we really want to encourage our patients to exercise, especially after a stroke, to prevent long-term disability and to prevent future events. This is just a nice table from the American Academy of Family Physicians on the things we can do to help prevent strokes in our patients who have already had them. So I think that's my time. Thank you all very much for your attention.
Thank you so much, Professor John Woller, for your insightful lecture on internist aspect of acute stroke. Now let's move to the last talk. It's once again a great privilege to introduce our last speaker at the Neurology Symposium hosted by Sloan College of Physicians. We are honored to have Dr. Janaka Waidyasekara, a highly respected consultant neurologist at the National Hospital of Galle, Sri Lanka. Dr. Janaka Waidyasekara's dedication to the field of neurology and his commitment to patients' care are truly commendable. Today, he will be sharing his valuable insights on brain health, WHO Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, IGAP, the way forward. Looking forward to learn from his expertise and experience. It's over to you.
Good morning, everybody, and thanks for that kind introduction. I'm tasked to talk to you on brain health, and during the session, I'm going to show you how an approach centered on brain health can transform healthcare outcomes, and then explore how WHO IGAP, the Intersectoral Global Action Plan, is aiming to shape up the future of neurology care across the globe. I have no disclosures. Human brain is the most complex and intricate structure that we have ever known. Arguably, it is the final frontier. Our brain is the command center of our body, seat of our memories, creativity, identity, and indeed, the very essence of our humanity. Despite being the most vital organ in the body, the health of the brain has taken a backseat. It is time that we bring it to the forefront. Brain health is an evolving concept which has gained popularity in the recent past and a subject which is critical to the future of our humanity. Brain health is defined by the WHO as a state of optimal brain functioning across cognitive, sensory, motor, emotional, behavioral domains, allowing a person to realize his full potential throughout the life course, irrespective of the presence or absence of disease. So as you can see here, brain health is not just about merely avoiding disease. It's about optimal development in childhood, resilience and adaptability in adulthood, and preserving function and independence into the old age. Brain health encompasses prevention, early diagnosis and treatment, rehabilitation, and social inclusion. Social inclusion refers to a person's ability to fully participate in society, ensuring equal opportunities and fostering a sense of belonging. Why should brain health matter? The answer is simple yet profound. Brain disorders carry an immense burden. Neurological disorders are the leading cause of disability worldwide, and it's the second leading cause of death, according to this Global Burden of Disease Study 2021. The same study reports that 1 in 3 people globally will develop a neurological condition at some point in their lifetime. To put that into perspective, virtually all of you in the audience, either directly or indirectly, will be touched by a neurological condition at some point. Burden of neurological disorders are going to rise due to the expected rise in number due to the aging population. We are all aware that people, due to improved healthcare, people are living longer, and hence the diseases which are common in elderly people, such as stroke, dementia, are going to rise in number. And finally, the cost and the burden of neurological disorders is enormous. According to this slide, economic burden or the annual cost of neurological disorders across Europe reaches a staggering 1.7 trillion euros. You can imagine the global situation. The disability posed by a neurological condition is largely a large contributor to the burden of neurological disorders. And this graph shows the leading causes of disability. The numbers you see here are the DALYs, or Disability Adjusted Life Years, which is a health metric used to quantify the disability. As you can see, the stroke is the leading cause of disability here, but then neonatal encephalopathy, migraine, dementia, diabetic neuropathy, meningitis, and epilepsy are the leading conditions. I need to point here, migraine and epilepsy are disabling conditions, but the disability from these conditions are not readily visible. The burden of neurological disorders is compounded by the stigma and discrimination, which can hamper life opportunities, increase the risk of poverty, and lead to difficulties in accessing care. The high burden on neurological disorders is further compounded by health inequities. 80% of the people with epilepsy in the world live in low and middle income countries. And that is where treatment gaps exceed 75% in most low income countries and 50% in most middle income countries. Disabilities associated with neurological conditions disproportionately affect women, older people, those living in poverty and rural areas. Health systems have not yet adequately responded to the high burden of neurological disorders. While majority of people with neurological disorders live in low and middle income countries, their needs are poorly recognized. With only 20% of countries, only 20% of low income countries have a dedicated policy for neurological disorders. Neurological workforce is heavily insufficient to tackle the treatment gaps globally. Availability of specialists in neurology and neurosurgery is 0.1 per 100,000 in low-income countries compared to 7 per 100,000 in high-income countries, reflecting a 70-fold disparity. So by now, I'm sure you will understand the fact that global burden of neurological disorders is profound and far-reaching. This understanding compels us to focus on one thing, which is prevention. Preventing neurological disorders is a vital component of brain health, focusing on lifestyle and environmental risk factors. Most neurological conditions often have a deleterious course, creating a major burden on patients, caregivers, and the society. This unique nature of neurological disorders signifies the strong need for effective preventive strategies and focus on brain health before brain diseases ensue. And this is where the term preventive neurology emerges. Preventive neurology is a paradigm shift where you move from a disease-oriented to a health-oriented approach. Our traditional practice focuses on treating established disorders, but the problem here is by the time these neurological disorders manifest clinically, the pathological changes have already established and most often irreversible. But this new model encourages promotion and preservation of brain health. I've shown here the front cover of a WHO position paper aimed at optimizing brain health. This recent paper appeared on the journal Neurology, indicates the growing interest in the area of preventing neurology. And here are a couple of examples, again, just to prove the fact that prevention works. First one, people with primary ICH, how to reduce their disability by predicting the functional outcome. And the second is, which is more famous, the American Heart Association's Life Simple 7 to reduce the cardiovascular risk. Why should prevention be so important? These numbers speak for themselves. Well, actually, there is evidence to say that 80% of the strokes are preventable. 40% of the dementias can be prevented. And it has been estimated that 25% of epilepsies are potentially preventable. We have learned already that stroke is a major contributor to the disability. This graph shows an interesting trend in the incidence of stroke in the recent past. From 1990 to 2010, the incidence of stroke have decreased by 12% in high-income countries and increased by 12% in low and middle-income countries. Now, we need to understand that the genetics of the world population have not changed. So this observation proves or tells us that whatever accounts for increased incidence in the developing world and the decreased incidence in the developed world should be modifiable. And this gives us the basis to believe that we can change things. Well, actually, there has been a lot of interest in stroke prevention, and there had been a lot of work on stroke prevention in the recent past, and here are a few examples. The InterStroke study was a landmark trial which was done back in 2010, which showed us that 10 risk factors are associated with 90% of the risk of stroke. And more interestingly, 5 risk factors, namely hypertension, smoking, abdominal obesity, diet, and physical inactivity, accounts for more than 80% of the risk of stroke. So the interventions that target these risk factors could substantially reduce the burden of stroke. Moving on, dementia is another major contributor to the disability from neurological disorders. Dementia worldwide, there are around 50 million people living with dementia. Number of people with dementia set to triple by 2050. But the good news is that modifying 12 risk factors can prevent up to 40% of dementias, according to this 2020 report of the Lancet Commission. In this picture, I've shown you the risk factors with their relative contribution. So I go through the more important ones here: less education in early life, hearing loss, traumatic brain injury, hypertension in middle life, and smoking, depression, and social isolation in late life. Here I want to draw your attention to a newly identified risk factor, which is social isolation. We humans are inherently social, and the human connections are a fundamental human need. And over 4 decades of research have shown us that social isolation is a risk factor for not only for dementia, but for depression, anxiety, stroke, and early death. It is not only the elderly who are affected by the problem. Many young people report that they feel alone and affected by social isolation. Despite the fact that we are in a digitally connected world, that's the fact. So as technology shapes our lives, we need to emphasize the fact that, it needs to strengthen human connection rather than decrease it or reduce it. So the magnitude of problem is so huge that the US Surgeon General featured this as a major public health burden or problem in a recent article. I've shown you that back in 2023. Moving on. Epilepsy is another condition which has a huge contribution to the burden of neurological disorders. Epilepsy has a huge impact not only on the patient, but also the family and the society they live in. The burden of epilepsy is huge, and here with this picture actually illustrate that sickness alters the whole atmosphere. The way I interpret this picture is that the patient is the toy and the guardian or the parent is the child. Around 50 million people worldwide have epilepsy. The risk of premature death is up to 3 times that of the general population. Nearly 80% of people with epilepsy live in low and middle income countries. But again, there's good news. 25% epilepsy cases are potentially preventable. Preventing head injury to prevent post-traumatic epilepsy, and adequate perinatal care, which can reduce epilepsy caused by birth injury. The use of drugs and other methods to lower body temperature in febrile seizures, and then prevention of epilepsy associated with stroke, focusing on cardiovascular risk factor reduction. CNS infections are a common cause of epilepsy in the developing world. Avoiding infections, particularly such as neurocysticercosis, can reduce the epilepsy burden worldwide. Actually, in endemic areas, neurocysticercosis accounts for 1/3 of cases of epilepsy. But here's an interesting fact. Even when you have epilepsy, up to 70% of people living with epilepsy could live seizure-free if properly treated and diagnosed and treated. But the problem is not everyone is achieving this due to disparities that I have alluded to. Migraine is another contributor to the disability, as you have seen earlier. But the disability from migraine or headache disorders are invisible. But if you take measures to avoid trigger factors, and if you start prophylaxis at the right time, things can be changed, or you can change a lot of things for these patients. So these are the risk factor or trigger factors for migraine, which could be avoided. Adequate sleep, not skipping meals, avoiding food that can trigger migraines, exercising regularly, managing stress, all these can be helpful to reduce the frequency and severity of migraines. And keeping a migraine diary could be helpful to pick up the trigger factors. And migraine prophylaxis, if started at the appropriate time, can reduce the frequency and severity of the attacks. So I want to re-emphasize at this point that brain health is a comprehensive concept that endorses the importance of protecting brain structural and functional integrity. Actually, the Federation on Neurology, under its brain health initiative, have identified these 5 factors as contributors to a healthy brain. Exercise, sleep, good environment, healthy diet, and access to care can make your brain healthy. Regular exercises can slow down the age-related cognitive decline and also helps lower blood pressure, avoid vascular risk factors leading to stroke. Sleep plays a crucial role in the function of the brain and the immune system and many other systems of the body. Good sleep keeps you sharp and focused. The general recommendation for all adults to sleep for 7 hours. Consistent and quality sleep allows the brain to dispose of its metabolic waste products and optimize memory. Environment also can influence your brain health. Environmental toxins, including contaminants in water, food, and the air, can all lead to neurological issues. The diet, in the same way that the diet is important for the entire body, it is important for the brain as well. But however, processed food, salt, and refined sugars can all promote inflammation and vascular disease, which are obviously harmful for your brain. Finally, access to care. Access to care is another thing which needs to be improved, as part of to achieve a healthy brain. So by now, I'm sure you all understand why should brain health matter. If our brains are challenged, this poses a significant risk not only to the individual's overall health, but also to the global development and productivity. At this point, I want to frame brain health not simply as a medical concern, but as a pillar for global development. Actually, the world has realized this in the recent past, and it has become a policy priority. Against this backdrop, World Health Organization has developed this IGAP, the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. The action plan was adopted back in 2022 at the World Health Assembly by 194 member states. IGAP is a roadmap designed to effectively address the burden of neurological disorders. Multiple stakeholders were involved in developing this action plan, and people with lived experience were involved in this process. WHO and its member states are now committed to prioritize brain health at national, regional, and global levels. IGAP provides the vision, goal, guiding principles, and strategic objectives with their action areas and targets. IGAP's vision is a world in which brain health is valued, promoted, and protected across the life course. Neurological disorders are prevented, diagnosed, and treated, and premature mortality and morbidity are avoided. and people affected by neurological disorders and their carers attain highest possible level of health with equal rights, opportunities, respect, and autonomy. Its goals are: one is to reduce the stigma, impact, and burden on neurological disorders, including their associated mortality, morbidity, and disability, and then to improve the quality of life of patients with neurological disorders, their carers, and families. IGAP has 5 strategic objectives: policy prioritization, timely and effective diagnosis, treatment, and care, implement strategies for promotion and prevention, which means promotion of brain health and prevention of neurological disorders, foster research and strengthen information systems, and then strengthen the public health approach to epilepsy. It relies on few guiding principles: people-centered primary health care and universal health coverage, integrated approach to care, I'll come back to it, evidence-informed policy and practice, which means translation of scientific evidence into policy. Intersectoral action is very important. This means that engagement of all relevant sectors such as health, social services, education, environment, and finance. Empowerment and involvement of persons with neurological disorders and their carers in care planning and policy development. This is a very important move. And finally, gender, equity, and human rights to address the disparities. Integrated approach refers to a holistic and a comprehensive strategy that incorporates various aspects of health and social care to address the needs of patients, their families, and carers. This involves collaboration between different disciplines to ensure a seamless continuum of care. Neurological disorders and some other health conditions are often linked by common preventable risk factors and potentially similar diagnostic, treatment, and resource requirements. Health and integrated approach is immensely helpful. IGAP has 10 targets for 2031. I have picked up the important ones here. 80% of the countries having a national strategy on neurological disorders. 50% reduction in the epilepsy treatment gap. And at least 75% of countries collecting data on major neurological disorders. In the context of epilepsy, these are the targets. 90% of people with epilepsy are aware about their diagnosis as a treatable disease. And 80% of people with epilepsy have access to care. And 70% of the patients with epilepsy achieve adequate seizure control. And these targets were advocated by ILE and IBE to be included in IGAP. Having understood where we stand, the next obvious question is, where do we go from here? The way forward should be to look at ways through which policy, innovation, and equity-driven strategies can help people with neurological disorders. To achieve what is planned or what is envisioned in the IGAP, there are a few key areas that we need to focus on. Integrated services which involves collaboration. Workforce development. We need to scale up neurologists and maybe to train more specialist nurses. Technology leverage. Usage of telemedicine and AI-assisted screening in neurology. Community empowerment, patient advocacy, public health campaigns, and brain health education. Research investment. Research must focus on local problems, so local solution for local problems. But at the same time, we need to collaborate with global consortia. Policy engagement. Neurology community as active stakeholders in health system reforms. IGAP offers enormous opportunities, and making them a reality requires the efforts of everyone. Governments should include neurological disorders in policies, integrate services across sectors, and eliminate discrimination. Academics and clinicians should work together with policymakers to support implementation efforts, including awareness raising and knowledge generation. Patients should be at the center of decision-making process, and their perspectives, experiences, and needs are instrumental in planning and implementation of an effective response. So in summary, neurological disorders pose a major global burden, yet remain under-prioritized. Brain health underscores the need to preserve structural and functional integrity of brain. WHO IGAP provides the framework to integrate this priority into universal health coverage. Brain health is human capital. If we lose brain health, we lose our capacity to be human. WHO IGAP is the roadmap. It is up to us to turn it from paper into action. So as the final slogan, I have this to say. The message is clear. The call is urgent. The time to act is now. Thank you.
Thank you very much, Dr. Janaka Waidyasekara, for this very informative lecture. So may I invite all three speakers on stage, please. To move on to the next part of this symposium, it would be a discussion with panelists. We are fortunate to have two esteemed expert panelists for this symposium. Let me invite Dr. Kishara Goonaratne, consultant neurologist, Dr. Ranjani Gamage, and Dr. Senaka Bandusena for us to continue the panel discussion of this symposium. Over to you, Ajantha.
Thank you so much. The first question from the speaker's point of view, I just want to ask from Dr. Kishara, in the context of WHO's IGAP policies, what do you see as the most practical first step the country like Sri Lanka, low-income country, can take to strengthen the brain health system given the challenges of limited resources?
Thank you. So my main interests are in epilepsy, and actually the IGAP initiative was actually initiated by the ILA, or the International League Against Epilepsy, and the 90-80-70 goal, that is to increase awareness on epilepsy by 90%, 80% getting access to treatment, and 70% being ideally seizure-free. So it's a tall order. The first thing is, I think, as a country, we don't have enough data to strategize the reduction in treatment gap. We don't really have data on the treatment gap. So I think our initial priority would be to actually, mobilize the easiest thing is to actually utilize an already existing system, which is, I think, the public health system. And we have public health midwives at the grassroots level dealing with the community. I think that's a very good place to start. And I think that's where we would probably focus on when it comes to, one, data extraction, and two, actually training these healthcare workers who are actually in the grassroots level, working with the community to pick up patients with epilepsy, and then secondly, to actually refer them and have a proper referral pathway. I think that we are in the process of actually developing such a strategy. But this is not a new thing now. The other thing is reduction in stigma. This also is a very important aspect. Empowering our own population is also very important. These are very things that have already been happening. I think Professor Ranjani Gamage can also expand on that, because I think since 2002 or 3, there have been several sort of strategies that have been incorporated on and off, but probably we need a little bit more consistency through, through the government, and they need to understand that this needs to go on. I think you can elaborate a little bit more on that, yeah?
Thank you very much, Kishara. I think Janaka gave a very good description about the importance of brain health. And I'm very happy, not that I'm happy, that there is focus on brain health, because it has come as the second most killer in the world. And I can give some advice from my own experience in epilepsy. We started our program in 2002, and if you take the first, one of the most important thing in the IGAP was we started when the patients are treated as outcasts. There were all the there were misbeliefs and misconceptions. People didn't know that it was treatable, and then the patients were mostly following the psychiatric clinic. And there was a treatment dropouts. Children were not taken into schools. From that point onwards, we have struggled 2 decades to bring this up when the WHO initiative was commenced in 2022. And by then, we have reached up to the level of establishing an epilepsy center. And we have gone through the roadmap, almost, I wouldn't say the destination, but a considerable amount we have to go. We were close to the destination, and what can we, how can we apply the IGAP to Sri Lanka and in the Sri Lankan neurology? This one thing is that we have to think of this cascade of targets to all our common neurological conditions. Now, the 60% of people being aware that they are suffering from epilepsy. So it can be applied to any other neurological conditions also. 70% that there's accessibility for treatment and affordability that can be applied and ensured. Then the 70% is that they live a normal, almost normal life after treatment. So those targets, cascade of targets, is a very good concept to be applied for neurology as well as for medical conditions even. And the other thing that strikes me is that action plans are far better. I mean, I won't say guidelines are not important, but action plans work in countries like ours. I started in 2001. The action plan was an epilepsy task force. And then we set out 4 targets, and we achieved almost all. But the advice or what we could get from the WHO is that this is more it is more organized, and it is intersectorial. And then it is easy. We can get funds, we can get the attention of our ministries to achieve the targets. But when we start something without those, it's where we don't get much help. So we have traversed in this journey We are almost near the road gap. In the road, we are almost near the target. And I think we can apply that to all the other neurological disorders, and then we can think of a better brain health in Sri Lanka. Thank you very much.
Thank you very much, Dr. Ranjani Gamage, for that valuable opinion. I think another important topic is stroke, a topic that's very close to my heart. Being a stroke expert, I think my question would be towards Dr. Senaka Bandusena. Having listened to how the Center of Excellence manage the acute stroke, I mean, what gaps do you see in our country, our community? How have we been doing so far for acute stroke management, and what messages, what challenges and what messages would you like to give to the audience to improve our acute stroke care in this country, Senaka?
Thank you very much, madam. I think it's a very important question. I think acute stroke care has come a long way. I think stroke care, the acute stroke care was transformed with the introduction of thrombolysis, and in Sri Lanka it was in 2008 when, under the leadership of Dr. Padma S, who is our co-chair here, we started the thrombolysis program. It was initially at National Hospital, and then since then it has spread to many hospitals throughout the country. Now, if you look at the 9 provinces, there's at least 1 or 2 hospitals in each of the provinces which have thrombolysis. So in a certain sense, we can be happy. And also we know that we are very fortunate that the drug is given free of charge to all our patients, right? But that is on one side. But when you look at the actual percentage of patients who actually get thrombolyzed, we find that it is a small percentage, because it's only about 15 to 20%. I think we don't have much data to support, but I think with my clinical practice, I could say that's about the range that we are seeing. So why is that? So there are many obstacles for thrombolysis in Sri Lanka, and I think the main problem is the time delays. Very often, now even the last casualty we had about 9 stroke calls, of which 7 were actually out of the time window. So we have time-dependent interventions, but the patients don't come to hospital in time. So how do you circumvent that? One of the main problems is, like, sometimes there are several reasons. One is patients don't identify stroke symptoms. I think in Dr. John Waller's lectures, he presented how varied stroke presentations can be. So there are very many different ways stroke can present, and then sometimes patients don't identify them as strokes. So that is a problem. And as clinicians, I think it is up to us to ensure that people learn how to identify stroke. And once they identify stroke, they need to kind of not wait and see. In Sri Lanka, there's this policy, sometimes you get something, you just wait and see whether it will go away, especially when it comes to neurological thing. There is a normal, I think even other countries, it may be the same. So that is another thing. I think we need to emphasize that if you have stroke symptoms, you need to seek treatment early, because otherwise you might miss the treatment windows. The next thing is they go to hospitals which don't have stroke care. For example, sometimes they go and see the GP. Valuable time is lost. Sometimes they go to Ayurvedic hospitals. Sometimes they actually go to hospitals which don't have thrombolysis. So I think that is another area that we have to kind of target to ensure that the message is clear that if you have a stroke, just go to a hospital which has stroke care. And in Sri Lanka, we have many hospitals with CT scanning facilities, and those are the hospitals that one should go in that sense. And then once the patient goes to the hospital, again, there are time delays sometimes. So CT scanning is a must. I think Dr. Woller showed the essential test that one has to do. Without a CT, you can't thrombolyze or offer any acute treatment, because we need to differentiate ICH from ischemic stroke. And when it comes to CT, again, I mean, certain hospital logistics sometimes determine. Even at National Hospital, there was a time when the ETU to CT, the distance was about half a kilometer or even more. And then that takes time. So fortunately now things have changed. Now we have an OPD complex where CT and ETU are in the same block. So I think other hospitals also may be having similar issues. So that's another thing. I think as a hospital, I think they have to find ways of minimizing the delay. Other thing is when you do a CT, to be able to interpret, because very often another delay that happens is the person who does the CT can't interpret the CT. And it's very rarely only you will get radiologists to actually help us in an acute setting. Ideally we would like to have that, but in reality, I think as a neurologist, I would say I don't think I ever got a radiologist to kind of read a CT in an acute setting. So we often have to do that ourselves. And even physicians who are involved with the acute stroke care, I think they need to learn how to do that. And of course, the drug itself. Now, the drug we used for acute stroke care used to be Actilized, but we switched to tenecteplase some years back, 2 years back. for a number of reasons. The main reason being it is very easy to administer. Just an intravenous bolus takes 5 seconds, whereas earlier the Actylase that was used was a 1 hour infusion. So in that sense, I think any hospital which has CT scanning and it's very easy to administer, and and we are happy that ASN took that initiative 2 years back, whereas the FDA only approved it this March. So I think we are happy in that sense. So I think those are some of the key things I think we can target. There are many other things, but I think time does not allow me to elaborate.
Yeah, thank you so much, Senaka. One short last question to Professor Ranjani Gamage in the context of neuromuscular crisis. Could you elaborate on additional reliable clinical or laboratory markers which is already interpreted for escalating ventilation at bedside or in clinical practice, madam?
I think I have nothing to contribute because Professor Chang did it very well. But 2 or 3 practical points. One is about prevention of people coming into the respiratory failure. One thing is that I have seen a lot of aspirations mimicking myasthenia crisis. And that is because they don't take the tablets before at least 30 minutes that is recommended before meals. And then they get into various aspiration issues and then they come. But however, the treatment is the same. And in the case of Guillain-Barré, it's better that we categorize, that is actually the aftermath care, to categorize or do the testings to see, because in our country, the limited ventilation facilities, we have to identify the people who can be weaned off ventilation early and also late. So I'm Sam, and I think in that regard, we have to refer the patients to the neurologist. And of course, Chang elaborated on early treatment. And one last thing about coming back to IGAP and also the WHO, I think it is the Sri Lankan action plans should be, we have to have our own action plans, because WHO directives are like ready-made shirts, but each country will have to tailor-made to their own settings. Thank you very much for your attention.
Thank you very much, Professor Ranjani Gamage and her team of panelists to come forward to take part in the discussion, and also the wonderful speakers here. So before concluding, now it's time to present a certificate of appreciation for the esteemed speakers and panelists. I'd like to call upon Professor Thashi Chang, Dr. Janaka Waidyasekara, and Dr. John Woller. In addition to the panelist list, Professor Ranjani Gamage, Dr. Senaka Bandusena, and Dr. Kishara Goonaratne. Thank you so much.
Could I now please invite Dr. Samir Moideen to award the certificates and letters of appreciation to our chairpersons.